So, welcome everyone. It's a great pleasure for me as the president of the International Society for Sexual Medicine to welcome you all from all over the world to our last webinar this year, Aging, Chronic Illness and Sexual Health, a topic that I know everyone working with sexual medicine will see every day in their clinical practice. Can I have the next slide, Meryl? So just to refresh your memory on the vision and mission of the ISSM, we have the vision that every human being has the right to a healthy and satisfying sexual life. And also our mission is that we want to be the most respected and trusted source of information, education, and professional development of human sexual health through the delivery of world-class publication, research findings, online and in-person opportunities for knowledge exchange worldwide. And this series of webinars is one of our missions that we really want to share knowledge from high-profile clinicians and researchers, and I'm so happy to have a very high expertise panel this day. The next slide. Just to remind you that as an ISSM member, you also have access to our journals. We have the Journal of Sexual Medicine, our open access sexual medicine and sexual medicine reviews, and we also have our video journals. So please, if you're not a member, become a member and get access to these very excellent journals. So the webinar series is something that we invented or started with when we all had to stay home and we were not able to meet in in-person meetings through the pandemics. And this is because we will not have or did not have our meeting in Japan in September as planned. We will hope have our meeting in November next year, but the webinars is a way to reach out for you as our members and share knowledge and research so we all have and stay connected throughout this pandemic. So the next slide. So it's a great pleasure to introduce to you our moderator today. It is Eric Chung. Eric is a urologist from Australia and holds professional academic appointments at the University of Queensland in Brisbane and also at the University Hospital in Sydney. Eric is very active in the sexual health societies. He's the Secretary General of the Asia Pacific Society for Sexual Medicine. He is chair for the andrology section within the Urological Society of Australia and New Zealand, and is also the current chair of our scientific committee for the meeting we should have had in Japan. So he's still the meeting chair for the meeting that we hopefully will have in Japan next year. And also he has just been appointed to be the chair of the membership committee in the ISSM. So it's a great pleasure to hand over the meeting to you, Eric, and welcome, and thank you for you that you want to take this task on you.
All right, well, thank you, Annamaria, for the introduction. Good morning, good afternoon, and good evening to the audience. Welcome everyone to the next installment of the ISSM State of the Art lecture series. Now, I'm really excited today to bring to you Dr. Faubion and Dr. Vasan, who I thought are really great speaker and leading authority on the field of male sexual and female sexual function. So each speaker has been tasked to provide some evidence-based literature on these topics and will share with the audience some strategy on how the impact of aging and chronic illness can have in terms of sexual health and sexual function. Next slide, please. So throughout this webinar tonight, what we have with you is that each speaker has been given a task to present for 20 minutes each. And we have plenty of time for Q&A at the end of this lecture. So feel free to ask some questions and type in those questions on the link below. And we look forward to having a very sort of engaging presentation tonight. So without further ado, I'd like to introduce our first speaker. So Dr. Faubion is the professor and chair of the Department of Medicine at Mayo Clinic in Jacksonville, Florida, and also the director of the Mayo Clinic Center for Women's Health. She has been appointed as the medical director of the North American Menopause Society in 2019. So Dr. Faubion will be presenting on female sexual function, menopause, aging, and chronic illness. Dr. Faubion, please.
Thank you so much. I'm really delighted to be here. Okay, so today we will be talking about female sexual function and menopause, aging, and chronic illness. And our objectives are to describe the prevalence of sexual activity and sexual dysfunctions in aging women, discuss the impact of menopause on sexual function, explain the impact of chronic illness on sexual function, and finally list ways to optimize sexual health and function with aging. So we'll start with the first objective, looking at the prevalence of sexual activity and sexual dysfunctions in aging women. So this is a US probability sample of over 3,000 women. It was published in 2007. The women were aged 57 to 85 years. And we know that older women, 75 to 85 years, are less likely than men are to be partnered, 40% versus 78%. We know the prevalence of sexual activity declines with age as well. And the most common problem that women experience in terms of sexual function as they age is low sexual desire. And over 40% of older women experience low sexual desire. Male partner physical health was the most common reported reason for not being sexually active in those women who were partnered. And this is a theme that you will see in some additional studies as well, that the partner health overall and sexual health has a large impact on female sexual functioning. So this is the NATSL study, a UK study, and it was published in 2013. It looked at almost 9,000 women, and it showed that women remain sexually active as they get older, but sexual activity declines with age. A full 1 out of 5 women aged 65 to 74 had vaginal sex within the last 4 weeks. Also of note, this study was actually updated last year, so this is very current data. Now, this is the MIDAS study. It was a cross-sectional study that was looking at sexual activity and sexual satisfaction in midlife and older women. They were looking at physical health, mental health, medication use, relationship factors, and how they related to sexual activity and satisfaction. What they found was that about 60% of women over the age of 60 were partnered and remained sexually active. The presence of a partner was the strongest predictor of sexual activity. And the factors that seem to be very important and related to sexual activity and satisfaction were communication with the partner, relationship satisfaction, and the importance of sex. What was not related to sexual satisfaction were a woman's age and menopausal status. And this was a study that was just published last year, a UK study, which looked at sexual activity and satisfaction in over 24,000 postmenopausal women, median age of 64. And it showed again that about 65% had a partner and about 1 in 5 were sexually active. So we're seeing themes here. These data are very consistent even across different countries. The primary reason for absence of sexual activity again was the lack of a partner. And the most important factors beyond that were the partner factors. So partner medical condition, partner sexual dysfunction, partners and your own physical health, the relationship. Also on the list were menopause-related symptoms and prescription medications. So why is this important? Why do we care? We know that sexual activity is important. A higher purpose in life is associated with sexual enjoyment. We know that sexual function is very closely related to life satisfaction. And sexual satisfaction is tied to emotional closeness. So we know that emotional closeness with one's partner is associated with better sexual function. The frequency of being very satisfied increases with age. It doesn't decrease. And it's important to note and important to emphasize to our patients that sexual activity is not always necessary for satisfaction. So this looks at the prevalence of sexual dysfunction. This is the PRESIDE study, and it was published in 2008 by Dr. Schifrin. We know that any sexual problem was found in about 44% of women. So again, very consistent across studies. And we know that sexual desire problems are the most common. When you look at how common the problem is associated with distress, about 10% of women are reporting low sexual desire that causes them distress. And about 12% of women were reporting some sort of sexual dysfunction associated with distress. So not a small percentage of women. And this was specifically looking at it in age groups. And we know that sexual dysfunction associated with distress is most common in the midlife women's health groups, but older women still have dysfunction, but there's less distress associated with it. So let's move on to the second topic, and that's discussing the impact of menopause on sexual function. So this is kind of hard to tease out because women hit menopause in midlife, and it's difficult to separate the impact of aging versus the impact of menopause on sexual functioning. This data is from the study of women's health across the nation, or the SWAN study. And it showed that the things that were associated with the menopause transition were vaginal dryness and associated pain, less arousal, less physical pleasure, and less emotional satisfaction. Also, low sexual desire was associated with the menopause transition. What was not associated with the menopause transition was frequency of sexual activity. So this goes back to the fact that women are still remaining sexually active, even if they're having vaginal dryness and pain. Also not related to menopause was the satisfaction with partner, physical pleasure, and arousal. And the key factor here is the importance of sex was the most important variable related to sexual functioning, and it was highly related to all outcomes. Also important were a woman's physical and psychological health and her relationship status. And we can't talk about menopause and sexual health without addressing the genitourinary syndrome of menopause, or vulvovaginal atrophy. This affects at least 60% of postmenopausal women, probably closer to 60% in those who have breast cancer. Symptoms are not just vaginal, but include vaginal dryness, itching, burning, and pain with sex, but also urinary symptoms like urinary frequency, urgency, and a higher risk for urinary tract infections. We know that this is significantly underdiagnosed and undertreated in women. Only about 7 to 9% of women who are affected are actually receiving treatment. We know that it doesn't get better with time. It's typically chronic and progressive, and unless treated, tends to get worse. And there are communication challenges and barriers on both the part of the patient and the provider. For example, women expect their providers to bring up this topic, but providers are often uncomfortable and often don't bring up the topic for a number of reasons, including not really understanding what the options are for treatment, and feeling embarrassed to talk about sexual function. So in an attempt to try to disentangle the age versus menopause question, and as it relates to sexual functioning, let's look at a group of women that go through menopause early, and those are women with premature ovarian insufficiency. That is defined as loss of ovarian function before the age of 40 years. It's really hard to disentangle all the factors that impact sexual functioning in this group. It's very complex. There are psychosocial factors such as a decreased well-being and poor body image, poor self-esteem, and loss of fertility, which can really impact sexual functioning. Loss of ovarian function can affect one's relationship with her partner, and even a willingness for that woman to start a new relationship. There's also the biological piece associated with premature ovarian insufficiency, and we know that women lose androgens as well as estrogens. So about 50% of our androgen production comes from the ovary. And we know that women with premature ovarian insufficiency, not just surgical removal of the ovaries, but who lose that function gradually, also lose androgen production. Depression is associated with this entity, as well as a higher risk of cardiovascular disease. And the etiology, so why it happened in the first place, may also impact sexual functioning, and that could be genetic factors, virus, autoimmune disease, chemotherapy, or radiation, so treatment for a cancer, for example. And then looking at early surgical menopause. So this might be a cleaner group to look at, if you will, because these women had their ovaries surgically removed rather than loss of ovarian function that might have taken some time. It's defined as surgical removal of the ovaries at, under the age of 40 years, and it results in a sudden and abrupt loss of not only estrogen, but estrogen, progesterone, and testosterone. And again, the impact on sexual functioning is very complex. So there are the psychological factors here as well, also biological. And we know this group of women also has a higher risk of cardiovascular disease, but also has a higher risk of sexual dysfunction that has been well documented in the literature. We also have to take into account the reason that the woman had her ovaries removed in the first place, which is very complex. And even in our database here at the Mayo Clinic, we have found that these women tend to be more sick in the first place. They tend to have had more adverse childhood experiences. There's more mental health issues in this group. And so the reasons for removal of the ovaries in the first place is a salient question and may impact sexual functioning. We also know from our data here at Mayo that estrogen quote unquote replacement, so actually giving estrogen back to this group of women that should have had it in the first place, may not mitigate all these adverse outcomes. And specifically we know that sexual dysfunction and mental health concerns are two of the things that do not seem to be totally mitigated by estrogen replacement. So let's move down the list a little bit further and look at the impact of chronic illness on sexual functioning. There are many medical conditions that impact sexual function in women. Cardiovascular disease is one of them, and we know that's the leading killer of women. The #1 killer of women is heart disease. So all of those factors that impact heart disease risk, like hypertension, like diabetes and metabolic syndrome, they all may have some effect on arousal, for example. But then let's not forget other factors like incontinence of urine and stool. There are so many women, and speaking just anecdotally from my own experience, incontinence of urine and stool is a big factor for aging women, and one they will often not tell you about unless you ask them. But it impacts all aspects of sexual functioning and even a woman's willingness to be sexual. Let's not forget about things that are more common in women, like dementia, which can impact sexual functioning, and then malignancy. And when we talk about cancer, it's not just about a reproductive organ cancer or a breast cancer. Any cancer that a woman may experience can affect her sexual functioning. Depression is another big one, and one that can and should be addressed by any provider that's taking care of a woman. So depression, this is a bidirectional relationship. Depression is associated with an increased risk for sexual dysfunction with a risk ratio of about 1.7, but the reverse is also true. Women with sexual dysfunction, or people with sexual dysfunction, men and women, have an increased odds of depression with an odds ratio of over 3. So when one sees a woman in your office with low sexual desire, it's important to think about mood issues. And the reverse is true as well. A woman with a mood issue, we must also question sexual function. Then looking at the treatment of depression, we also have some issues here in that a lot of the antidepressants are associated with sexual dysfunction. As you'll see here, some are less offensive than others in terms of sexual dysfunction. Bupropion is one, vilazodone is another, and mirtazapine is one. Nifazodone has actually been pulled off the market here in the United States. But the 3 pluses is over 25% frequency of sexual dysfunction. So if you start a woman on an antidepressant that is going to cause sexual dysfunction in over 25% of cases, a lot of these people will stop their antidepressant without even telling you because of sexual side effects. So it's really, really important to understand the sexual impact of an antidepressant. It's also important to note that people experience the sexual side effects of antidepressants before they will get the antidepressant effect. So unfortunately, they're not yet feeling better in terms of their mood. Another important point is it's much better to treat the depression. You say, okay, well, let's just not treat the depression and we'll just deal with it. Sexual function is much better with treated depression than with untreated depression, even despite the side effects of the medications. Okay, so finally, let's list ways to optimize sexual health and functioning with aging. And this is a whole other lecture, so we're going to go at it from a high level here. One is maintaining a healthy lifestyle and reducing cardiovascular risk, keeping in mind, again, this is the #1 killer of women. I guess I should preface this all by saying the first thing to do is actually have the conversation. So bringing up the topic with all of our female patients. This is something I do with all my female and male patients. I see men in my practice as well as an internist. And sexual function is important. And with all of my patients, I bring it up in the office. So the #1 thing is bring up the topic and ask about it. So maintaining a healthy lifestyle, managing mood disorders is incredibly important, as we discussed. Treating genitourinary syndrome of menopause or vulvovaginal atrophy, addressing partner factors. We cannot address female sexual dysfunction without addressing the partner issues. So one, finding out if she has a partner. Women can be sexual even if they don't have a partner, but asking about partner status is key. And then partner sexual function, partner physical function, partner emotional status as well. And then facilitate adaptation of chronic diseases. It is our job as providers to make sure that we help women and their partners be able to continue to be sexual despite disability and aging issues. We all are going to have aging issues. So for example, a hip replacement. How are we going to deal with sexual function after a hip replacement? Talking about the sexual function effects after a heart attack. Talking about the importance of sexual activity despite dementia and chronic illness and aging. It is our job to really make sure that we address these issues as we take care of our patients. And then one last thing I'll leave you with is the ISSWISH process of care for management of hypoactive sexual desire disorder in women. This was published in 2018 and is really a nice way to go through the whole process of looking at low sexual desire in women and how to manage it and all the biopsychosocial factors that can impact it and the management options. So take-home messages. The prevalence of sexual problems in women increases with age, but associated distress decreases. The presence of an intimate partner is predictive of sexual activity in older women. Sexual function changes associated with menopause include decrease in sexual desire and an increase in vaginal dryness. Genitourinary syndrome of menopause is prevalent and undertreated and adversely impacts sexual activity and satisfaction. And there are many medical conditions and medications that have the potential to impact sexual functioning in aging women. And it's really our job as providers to help women navigate this time of their lives with a healthy sex life intact. And with that, I thank you and I look forward to your questions.
All right, well, thank you, Dr. Faubion, for the interesting and wonderful insight into female sexual function. I'd like to remind the audience that please feel in to type in the question on the Q&A because once Dr. Vasan finishes his talk, we will go to the Q&A for both Dr. Faubion and Dr. Vasan. So Dr. Vasan is the president of the South Asian Society of Sexual Medicine and also is the head of Department of Andrology at Anchor, Bangalore, India, and the director of the fellowship program in andrology and men's health at the Rajiv Gandhi University of Health Science. So he has been quite prolific in social media in India. So I'd like to welcome Dr. Vasan to give his opinion on male sexual function, aging, and chronic disease. Dr. Vasan, please.
Thank you, Eric, and thank you, Annamaria, for this opportunity. I'm going to take you through. We all know that that in the male's sexual life, as we all age, there is a decline in libido, there is an increased time for arousal, and there's a more rapid reversion to the pre-arousal state, and there is poor quality of erection in the male, poor quality orgasms, prolonged refractory period. And older adults are likely to place higher value on their sexual health and rights than previous generations, And research mainly from the Western countries, we don't have much Indian data, consistently demonstrates that majority of older adults are sexually active, and that sexual activity and intimacy play a role in their life satisfaction and psychological well-being. And we also know that good health is shown to be a significant predictor of maintaining sexual interest and enjoyment among partnered individuals in various age groups. And the factors which affect sexual functioning in the elderly are multifactorial. One is physiological, the pathological, behavioral, or psychosocial. Now, I'm going to concentrate on the pathological mechanisms because we from India, I'm from the Asian subcontinent, we are the diabetic capital of the world and probably the hypertensive capital of the world. And we see a lot of aging men. Among them, 68% of men have hypertension because of which there is ED. 60% of men have ED with dyslipidemia. 20% of men with ED have diabetes. And 11% of men have depression. And 32% of ED men have positive stress tests. And 20% of men have significant coronary occlusions. And the pathogenic mechanisms we are seeing in this population is predominantly the metabolic syndrome. And this is because of your either genetic alterations or visceral obesity, insulin resistant, increased sympathetic activity, which leads to sodium retention and hypertension, and predominantly causing endothelial dysfunction. And the similar mechanism for dyslipidemia and also food intake. So this is what we see, and this is what is the increased sympathetic activity which is associated with metabolic syndrome, where you have various organs which are affected, and consequently these men suffer more mechanisms of endothelial dysfunction. And so one of the challenges we have had is that many of these patients do not self-report, and they only report after a direct questioning. So one of the most important factors we do is that in these men, we do screen for ED, all these older age men, of an underlying coronary disease, uncover diabetes, or detect dyslipidemia, reveal the presence of hypogonadism, or identify occult cardiac disease. Many of these men with ED show decreased quality of life because of distress, depressive symptoms, decreased self-esteem, diminished quality of life, and also which affects their interpersonal relationships, especially in the Asian subcontinent. So the algorithm we follow is always ask for the problem, legitimize the problem, and if there are limitations in managing the problem, then you refer. If you feel confident, then you open up for further discussion and evaluation and work together to develop a comprehensive treatment plan, which is the algorithm we follow. And we all know that ED is predominantly vascular, especially if you have metabolic syndrome and other comorbidities, because of the risk of oxidative stress, which induces endothelial damage, which causes functional alterations, leading to structural alterations, which can have disastrous consequences in these men. And we know there is a lot of similarity between endothelial dysfunction, which is the primary cause for erectile dysfunction, as well as coronary artery disease in terms of the pathophysiology, both having a similar mechanism in its pathogenesis and its progress. So what happens with men with aging and vascular risk is there is increased arterial stiffening, loss of arterial elasticity, reduced arterial compliance, and consequently there is a higher risk of myocardial infarction. And this is what it is. So when you have endothelial dysfunction, gradually it can progress to an atherosclerotic event and consequently plaque formation, and then you have the clinical sequelae of the plaque formation. So the basic workup, we all know this is to have a good medical and psychosocial history using your validated instrument, identify other than ED, what are the common sexual problems, or identify the common causes of ED, identify risk factors, and this is an algorithm which we all follow. And then you have the focused physical examination, and you have your glucose and testosterone testing and other way. So the clinical evaluation is done to identify men with low risk or intermediate risk or high risk. basically because you can manage low-risk patients of erectile dysfunction in a primary care setting. If you have an intermediate risk, then you require cardiovascular risk assessment and re-stratification. And if you have a higher risk, your sexual activity needs to be deferred until cardiac condition is stabilized. So what are the newer tools we use in order to identify this intermediate risk and high risk? How do we classify them? One of the basic screening tools we have used is your metabolic markers, which is your cholesterol and your diabetes assessment, your CRP assessment, your homocysteine assessment. All these are the metabolic factors. Now there are new factors which are available to assess more aggressively the vascular risk which an individual has, because one of the management strategies of ED is to primarily treat ED or to correct the factors which are going to cause more morbidity in a patient because of the vascular factors which he has or vascular pathology he has, and reversing those factors or addressing those factors. And this is where these various tools are coming into focus. So one of the factors we nowadays focus on is assessment of the endothelial function in order to detect early derangement, because this might facilitate a proper categorizing of the ED, the severity of the ED, and then detecting whether there is any vascular risk. So in order to understand who are the individuals who require endothelial assessment, we have our various scoring mechanism, which is the International Index of Erectile Function or your SHIM score, and classify individuals with poor score with comorbidities. Or you also have men who are obese, smokers, high stress life, family history of a coronary event or a vascular event or a sudden onset of ED. Then we know that these are individuals with higher risk and who may require endothelial assessment. And the endothelial assessment which could be done in the doctor's office is usually a brachial artery ultrasound, or nowadays we do the fingertip assessment. It is with the concept of detecting the vascularity of the brachial artery on a flow-mediated dilatation, which is endothelium dependent, and understanding whether the endothelium is healthy in a given individual based on vascular reactivity. So this is what is the brachial artery flow-mediated dilatation. There are various tools which are available to assess brachial artery mediated endothelial flow, especially in the terminal arteriole, and typically the index finger is used to assess the terminal arteriolar endothelial assessment. The second assessment is, one is to assess peripherally whether the vascularity is okay in terms of endothelium. The other is to assess the pulse wave velocity, which gives you an assessment of the medium-sized arteries, and typically used is the carotid to femoral pulse wave velocity, and understanding whether the velocity values are abnormal, which gives you an early indication of dysfunction of the vascular compliance in a given individual, which puts them to a higher risk, and also you could possibly detect early morbidity. So that there are very many different measures of pulse wave velocity. One is to measure the arterial stiffness, and you use the systolic and diastolic blood pressure augmentation index. These are minimally invasive office procedures, especially useful in a comorbid dyslipidemic or metabolic syndrome population, which is what we are seeing more and more in the Indian subcontinent. And this is the measure we use. So the treatment algorithm we follow is understanding whether the patient, or asking directly the patient whether he has erectile dysfunction, classifying the severity of erectile dysfunction, then doing a risk stratification, using additional tools of evaluation in form of endothelial assessment or a pulse wave velocity assessment. These are all done in the office so that you could understand whether the patient has a higher risk. Additionally, we know many of these men nowadays have andropause or male menopause or male aging induced low testosterone. So you have various scores wherein you can assess the signs of low testosterone in these individuals, and then you again decide how significant is this testosterone induced or low testosterone induced male aging phenomena or andropause. And you have, again, it could impact the sexual function, it could impact the physical activity, or it could impact the psychological capacity of an individual in terms of his energy, fatigue levels, and various parameters. And then build an algorithm of whether you want to manage the andropause along with erectile dysfunction in a given individual. So the algorithm follows in terms of andropause assessment, adding a treatment plan for andropause if it is detected, and then you come into the phase of medical management of these individuals. And this is where we use sexual frequency. And if the sexual frequency of a given individual is less than 2 per week and it is predictable, he is a candidate for sildenafil. If it is not predictable, he is a candidate for tadalafil. And if the sexual frequency is more than 3 per week, we use tadalafil 5 milligram daily plus an on-demand dose. We in India start with the minimum dose and up titrate. There are countries where they start with the maximum dose and down titrate. But in Indian patients, they are not tolerant for the side effects, and we always believe we start with the minimum dose and up titrate the dosage. So along with that, we have an algorithm to manage the male andropause, wherein we go by the testosterone value, decide whether it is low, borderline, or normal. And if it is low, you repeat the measurements of LH, FSH, and prolactin, confirm whether the testosterone is low, or you could measure free testosterone also, and then plan your treatment according to the level of testosterone, and deciding whether there is an additional need for a testosterone replacement in that given individual. Of course, if you are replacing the testosterone in a given individual on a regular basis, then you need to be cognizant of the fact that the patient requires a digital rectal examination and a confirmation with the PSA and a lipid profile and a hematocrit, and these needs to be monitored on a periodic basis. We do it once in 6 months once we standardize the dose in a given individual. So now, if a patient is not responding to treatment, then you have the matrix strategies of treatment. You could use a central initiator or a central conditioner or a peripheral initiator or a peripheral conditioner. And these are various drugs in the armamentarium to facilitate a natural erection in a given individual who has endothelial dysfunction or an erectile dysfunction. You classify these individuals and then you plan your strategy depending on whether he's a PDE5 responder, non-responder, whether you want to add a drug which will facilitate a better erection in these given individuals. Now, there are some new modalities which are emerging on the basis of erectile dysfunction. When you have endothelial dysfunction or when you have pulse wave velocity abnormality, when a patient is not responding to erectile dysfunction, there is nowadays evidence emerging that low intensity shock wave may be useful in these men with erectile dysfunction, with many clinical studies reporting encouraging results in its use in improving the erectile function with good safety records and short-term durability. However, there is need to define the subgroup of ED population which is best suited for the low intensity treatment protocol. And there is a need for more stringent randomized controlled trials which are warranted before there is acceptance of this low intensity shockwave therapy as a standard of care in ED. Additional modality, which is the PRP or the platelet-rich growth factors. Again, there is very limited data. There is some studies which suggest an improvement in international IIEF score by an average of 4.14 points after platelet-rich factor injections. However, the guideline is that available data show lack of adverse reaction with PRP treatment, that studies we have found were limited by small groups. That is why there is safety and effectiveness on the data should be taken carefully. It is important to mention at this stage that PRP therapy has potential for treating male sexual dysfunction and may be useful. However, data is very limited. So to my take home is that we see a lot of population which is aging, which has metabolic syndrome, and I have covered mainly the pathological way of detecting whether these men have significant vascular compliance or vascular endothelial dysfunction or compliance issues, which allows us to risk stratify these individuals early. We use additional tools for evaluation of endothelial assessment and pulse wave velocity assessment, re-stratify these individuals, and then plan their treatment, look at their testosterone levels or identify men who have andropause, and then suggest treatment plans and give them the option of shockwave therapy or platelet-rich plasma, as it is investigational at this stage. And so my take home is that management of sexual function in an elderly has several components. It has a physiological component, it has a pathological component, it has a behavioral component, it has a psychosocial component. I have basically covered only the pathological component, which is what we deal with day in and day out in India, and involve the other groups in terms of psychiatrists and others who will manage the psychophysiological, behavioral, and psychosocial components. Thank you very much.
All right, well, thanks very much, Dr. Vasan, for the wonderful talk. So now we're open to the Q&A section. So I do have a first question for Dr. Faubion. So is there any role for systemic HRT, hormone replacement therapy, in terms of improving sexual function in women? And part B to the question is that what is the role of testosterone in female sexual function?
Wow, two complicated questions. So on the question about hormone therapy, estrogen specifically, there has been a Cochrane review on that, and it really is the impact on vaginal dryness that estrogen seems to help the most. And so I think it's in addressing the genitourinary syndrome of menopause. It does not seem to have a huge impact on desire. Short of the fact that women with vaginal pain, pelvic pain, pain with sex, dyspareunia of all sorts, will have low desire as a secondary component. So it impacts sexual function in that way. But the biggest effect is on GSM, genitourinary syndrome of menopause. Now, testosterone is another factor, and you guys are probably aware of the consensus statement on androgens that was published in the last year, which was excellent. And really the only role for testosterone is in low sexual desire. There's the most data in postmenopausal women. It is not for anything else. It is not for fatigue or depression or anything else, but low sexual desire. It has been proven to be effective in for all aspects of sexual functioning. It seems to help with, but in women that are postmenopausal with or without estrogen. So the most common scenario that I would consider testosterone would be for those women, for example, who had an early surgical menopause, had their ovaries removed at a young age. I think there's a good argument for that if you've tried estrogen therapy and things are fine except for low sexual desire. I think that would be a reasonable case. I also have many postmenopausal women after natural menopause who are doing fine in terms of the vaginal health piece, but still have low sexual desire. Now, it's important to go through the biopsychosocial model and rule out everything else that can be contributing as well, because very frequently there are many things impacting female sexual function, and it's not just a loss of testosterone issue. So I would say far and above everything else, go through the list, talk to the patient, find out if there's a biological, psychological, relationship issue, a sociocultural issue. And then when you get down to the end, yes, there can be a role for testosterone in some women.
Perfect. Well, thank you for the comprehensive but abbreviated version of the HRT. We got a question from one of the audience about antidepressant causing sexual dysfunction in women. Do stopping the antidepressant can actually reverse the consequences of the sexual dysfunction?
Yes, most of the time it can actually, it is reversible. So no, it's not a permanent problem that people are experiencing. But it's important to note that the depression can cause sexual dysfunction as well. So you can stop the antidepressant, but if you haven't fixed the depression, you still may have sexual dysfunction related to that.
Thank you. So there's a good question here from one of the audience is that as we know, we are currently in the COVID pandemic. So there's a lot of social restriction and isolation. So one of the audience is quite interested to find out whether is there any data about aging and impact on masturbation in terms of the frequency and the satisfaction with regards to masturbation. Do we know much about the data on masturbation in older women and also older men?
I haven't seen frequency, satisfaction, interest data. I did just quote you when we were talking about the NATSAL study, which was just updated last year. There were some data on masturbation, and 10% of women in that 65 to 74-year-old age group had masturbated in the last year. And that's data from 2019. I don't know that I've seen data related to frequency, satisfaction, interest, etc. So I think the comment that they made was that some women may use this who are having pain with intercourse. It may represent a way to have women remain sexual. I would agree with that, and self-stimulation, use of a vibrator, etc., may be a healthy way to deal with that. But then I would also emphasize the importance of having sexual pain evaluated. So it is treatable, and we shouldn't relegate those women to not being sexual with a partner because they're having pain.
What about Dr. Vasan? In men, is there any data about masturbation in aging men, and is there any role for that to try to improve sexual function?
I mean, I'm not aware of any data from the South Asian region, which I represent, on masturbation or any study which has been published from the South Asian region. Nor I'm not sure whether there's any. I have never looked at this topic. Honestly, I've never looked at masturbation in per se in older men. It's a very interesting question, but I'm sure I have not looked at this from that angle. But we don't have any publication from the South Asian region.
Now, another question from the audience is that, as we know, we're trying to be more holistic in terms of our approach to managing sexual function. So a lot of time when we see patient, we really like to include the partner. In terms of female issue, for example, in gynecology clinic, how often do we see men or their partners, be it from an LGBT community, attending with the female to a gynecology clinic with a sexual dysfunction?
Was the question, how often is the partner?
How often and how do we sort of change the perception then?
Of LGBTQ couples or?
Yes.
Yeah. Well, I haven't seen studies, so I can speak anecdotally. And in our sexual medicine clinic, yes, we encourage the partner to be engaged. And in fact, if you don't engage the partner, you have much less success, in my experience anyway, in getting to the root of some sexual health problems. So regardless of the sex of the partner, we include them in the discussion, because you can't get at a sexual function problem without engaging the partner. So yes, we do, for sure. We don't have that many LGBTQ couples in our practice, but I think, and that group is definitely underrepresented in the literature as well. So I think we all need to do a better job of being cognizant of including that group specifically in manuscripts. Good question.
A question for Dr. Vasan. As we know that men are aging and also starting to accumulate a lot of medical issues, so like hypertension, diabetes, metabolic syndrome. So some of these patients, PDE5 may not be appropriate. Are you suggesting that these men should turn to regenerative therapy as the solution for their erectile dysfunction?
No, like I said, like I presented, what we do, at least in India nowadays, is that we classify these men and we try to find out whether they have significant endothelial dysfunction. And if they have significant endothelial dysfunction, and also manage their diabetes and hypertension. And if they are non-responders to PDE5, we have tried combination therapies. And we go the same way as your first line therapy or second line therapy. We offer them injections, penile injections, self injections, or a vacuum device. And we also offer them the shockwave therapy, which is experimental at this stage. And it's a dialogue and a discussion. And if the patient opts for it, many of these men nowadays are opting for these therapies, knowing very well that the success rate may be limited. And we are also gathering data in the due process. So this is a dialogue. I don't think there is one fit all in this group of patients. And we go step by step. And in some cases, we do offer prosthesis as a surgical option for these men who want to lead an active sexual life.
Great. So this is kind of a controversial question. As you know, many people, as they get older, sometimes can develop dementia. So when you're faced with a partner who has dementia, what do you sort of deal with in terms of the other partner who are still sexually active? How do we sort of tackle this issue in the, I guess, both in the setting of medical, legal implication for where a partner is demented and not able to consent to sexual functioning? Faubion?
Wow. Okay, that's a difficult one. You know, I think there are many stages of dementia, and you know, I'm not going to speak so much to the medical legal part because I don't have that experience and expertise. But what I will say is that I take care of many couples that have one partner with the beginnings of dementia, and I can say that intimacy is incredibly important for that connection between the couple. And I think that one thing to note is that some people with dementia become hypersexual, and that may be an issue for the partner. And so ensuring that that we're even asking about sexual function, you know, so maintaining the connection between the couple, also being mindful of the fact that hypersexuality may be a problem. And then this gets into managing behavioral issues in any demented patient. As in terms of a vulnerable adult situation, I think that gets into if someone isn't partnered, doesn't have a regular partner, is a vulnerable adult, then I think you would treat them as you would any vulnerable adult who needs protection, right? So for whatever that's worth.
All right, Dr. Vasan?
No, I'm basically a urologist. I deal with men who have metabolic syndrome and erectile dysfunction, but if they have a comorbidity like dementia or a psychiatric illness, I would probably lean on my colleagues in psychiatry than trying to manage them primarily. So I have very limited experience in that area.
Okay. Well, another question for you, Dr. Vasan, is that you mentioned that diabetes is on the rise in Asia. What about alcoholism and the impact of alcoholism on sexual functioning?
Yeah, this is something which we see. There are a lot of, I mean, I do agree that there is a lot of alcoholism is on the rise. And we do see that not all men who have alcohol get impacted. And the pathophysiology seems to be the same. They all develop vascular or liver problems at the end of the day. So the pathophysiology in vascular, if it is vascular, the treatment management seems to be the same. Of course, you do manage the alcoholism, or you need to control the alcoholism in some way or the other. But the pathophysiology of excessive alcohol intake seems to be vascular. So the management stays the same.
Thank you. Now, we sort of mentioned about endothelial dysfunction as a cause of erectile dysfunction in men. What about women? Do endothelial dysfunction play a role at all? Dr. Faubion?
Yeah, I think there's some preliminary evidence for endothelial dysfunction in diabetes, for example, but how, you know, to what degree that impacts sexual functioning in women hasn't really been well defined yet.
There's a question about one of the slide that you presented, Dr. Vasan, about the oxytogenic initiator of sex. What do you mean by that in terms of something that can actually stimulate sexual desire?
oxytocin or apomorphine has been used. Now it is not available in India. We did use in a limited number of patients initially, and we found a lot of nausea in this group of patients. People have used various types of drugs, yohimbine, trazodone, all sorts of drugs in terms of as central initiators. And apomorphine was a specific drug which was approved, but now it has been withdrawn from India and we don't have it available. My experience with the drug was very limited and I didn't see much benefit in using the drug.
Right. And do you see a lot of issue with older men quite shy from seeking medical health and perhaps resort to some of the alternative complementary medicine in terms of treating sexual functioning?
Absolutely. India is a country where I think still sexual function is, the discussion about sexual function itself is evolving. And I think many of these men are driven by women for taking treatment than themselves primarily. That's what we do see in India. Women seem to drive men for treatment of sexual dysfunction than themselves coming openly to the clinic. And many of them, before coming to the clinic, will self-medicate. And many of them come to the clinic after self-medication or over-the-counter prescription, because in India, many a times you can get drugs over the counter, and consequently they use that and use it irrationally and then find no benefit and then land up with treatment. But unlike I think the other Asian countries, we don't seem to use too much of alternative medication like your other herbs and other things, which is not very popular in India. But it is morely the allopathic medication or the mainstream medication which is used in an irrational way, and then they land up in the clinic.
Thank you. So one question for Dr. Faubion is what do we do in terms of investigation for women with sexual dysfunction? Is there any sort of blood test that we can organize as part of the initial workup?
That's a great question. In general, blood tests are not required. However, I think a general examination is worthwhile. And for me as an internist, I would be looking at, does the patient have diabetes? Do they have other cardiovascular risk factors? Do they have hypertension? When you look at testosterone, there's a question here, which I think is a good question to answer. Do we need to look at testosterone levels in women before using it to treat low sexual desire? That's a great question. We won't use testosterone levels to define an androgen deficiency syndrome in women, because probably we're not able to detect very, very low levels, and there's never been an association between level and diagnosis of HSDD. So you can't use a testosterone level to diagnose HSDD in women. However, we get levels at baseline if we're going to treat a woman, to then have them as a baseline and then follow the levels on treatment. So we would use the baseline levels to ensure, one, they're not at the high end already, but then to treat women to the mid to upper range of the normal premenopausal level when we're treating women. Good question.
Thank you. One question for Dr. Vasan is that in terms of the use of PDE5, as you know, PDE5, there's sort of so many PDE5 coming to the market, and some of them have become generic now. Is there any sort of difference in terms of the use of PDE5 for elderly men?
No, I find elderly men, because what we do is, if they have significant endothelial dysfunction, one is we are finding that on-demand PDE5 doesn't seem to work very well in older men. They require some amount of PDE5. We use tadalafil 5 milligram on a daily basis and ask them to take an on-demand tablet whenever they want to have sexual activity, especially if they are if we have diagnosed endothelial dysfunction. That seems to work better. Unfortunately, in India, we have only 3 brands, which is the sildenafil, tadalafil, and udanafil. I do not have any experience with any other brand because it's not available in India at this point in time.
Thank you. One question for Dr. Faubion is that why do you think that there's such a little in terms of availability of drug therapy for female sexual dysfunction as compared to men?
Why is it so difficult?
So difficult to develop drugs for female sexual dysfunction as compared to male sexual dysfunction?
Well, I'm not sure it's difficult. It's where the interest is, right? So, I mean, drug development is the same for men and for women, except that there's not as much attention placed on drug development for women. So I think that just gets back to the fact that we don't have a huge focus on female sexual function in general. It's not well addressed. It's not well, I mean, we can hardly talk about vaginal dryness, let alone low sexual desire and sexual satisfaction. So I think it's just an appreciated problem for women. We don't discuss it enough, and that leads all the way down the pathway to drug development. We've also been very slow to study and test drugs in women in general. And as you know, many of the side effects associated with drugs and the drugs that are pulled off the market are due to side effects in women. And that's because we never studied them in women in the first place. So this is a much bigger issue than just sexual dysfunction drugs. But I think it just speaks to the fact that we don't talk about female sexual dysfunction.
In terms of regenerative therapy, it seems that laser vagina therapy seems to be answer to a lot of female vulvar disorder. What is your opinion about the use of laser therapy, especially for female sexual dysfunction?
Well, it hasn't been proven. It hasn't been proven. That's the biggest problem. I just saw a study published on laser therapy for pelvic organ prolapse, and it doesn't work. So there are no data on this quote unquote vaginal rejuvenation. Now we do have some data on laser therapy for genitourinary syndrome of menopause. We still need longer studies that are sham controlled and have longer term follow-up. So we don't have the long-term safety data that we need. And we also don't know how often treatments will be required. I think it's a promising therapy, but when you get into using it for all kinds of regenerative therapies, we don't have data for that yet.
Perfect. Right, thank you. One question for Dr. Vasan is that, do you think that we will be probably moving towards an era of using regenerative therapy rather than standard medical therapy for erectile dysfunction in men, especially as the demand for efficacy increases significantly?
Absolutely. I think there are a lot of groups which are working on regenerative therapies, and there are some papers which are coming out which suggest various types of protocols which are used both from the point of view of shockwave therapy as well as platelet-rich plasma injections. The challenge has been the numbers are very small and there is very limited data at this point in time. But there are a lot of groups which are working on it, and I'm sure going forward, if we are able to standardize the right subgroup of patients who will benefit from this and develop an algorithm of what needs to be done in terms of investigations, that would become a part of the treatment armamentarium of all these types of erectile dysfunction.
Great. So one question to each of the speakers. So the last question to Dr. Faubion is that, what would you envisage as the future in terms of the research area that we really need to focus on to try to sort of bring female sexual dysfunction management to the next step?
Oh, wow, that's a big question. You know, I think there will be more drug development for women for low sexual desire. I think that's something that is needed. I also hope that we can eventually get testosterone to where it's government approved for women. That would be a really big step. So I think the additional long-term safety data that the government agencies are asking for would be something to aim for women. Perfect.
And now question to Dr. Vasan as well. Where do you think we should be focusing in terms of male sexual dysfunction in the next era?
I think like we are doing a pilot project where we are looking at various stem cells, both your umbilical cord stem cells and mesenchymal stem cells and ultrafiltration of fat. And there are various groups which are working on it. I think that's the way to go forward, because but there are a lot of challenges in that area. But I think stem cell would become the main standard of therapy going forward in a couple of years.
All right, well, thank you very much again. I'd like to take this opportunity to thank both Dr. Faubion and Dr. Vasan for such an exciting talk into a very difficult topic. And certainly, I think the audience appreciate your frankness in terms of the Q&A answer. So before I go today, I'd like to take this opportunity to thank Annamaria and also ISSM for giving me the opportunity to give you this webinar that I think is quite timely and quite useful as well. And also, before I sort of depart, I'd like to take this opportunity to wish everyone a safe and happy Merry Christmas and also New Year 2021. Thanks a lot. I'll pass over to Annamaria again.
And thank you, Eric. I just want to thank you, Dr. Faubion and Dr. Vasan, for giving excellent talks and sharing all your knowledge. And it's so nice to have you here. I have so many positive comments from the participants. So thank you so much. And thank you to Eric for planning this webinar and moderating it. And thank you to Meryl for arranging all the practical things. So I just want to remind you that in January, we will have our next webinar, which will be on sexual addiction, pornography, and hypersexuality. So please put the date in your calendar already now. It's January 28th. And finally, I just want to wish you all a very, very happy holiday and a happy new year. And I hope that you will have a lot of joy and love with the people that you love. And I hope to see you all next year. And thank you for participating in the webinar. Take care, all of you.
Thank you.